Welcome back to the Interprofessional SPACe podcast. In this episode, we are sharing the second part of our conversation with midwife and Professor Zakiya Nosakhere. Welcome to part 2 of Interprofessional Trust, Teamwork, and Transformation, Lessons from Maternity Care.
So I'm going to take a little bit of a turn here. One of the things I was excited to talk about today was the first time we met and how that led to the collaboration that we did. So for folks who might not know, Suzy invited me to go visit Nottingham, which was great. And that was a fun trip. And at that first visit, that's where we met, Zakiya. And you talked about FGM, which honestly, so again, med-surg nurse, I remember learning about it in nursing school, but is not my area of expertise. And I said, I'm going to need a refresher, please. And you pulled up a laptop and you were talking about, and so you re-educated me. Thank you for that. And from that, the three of us got talking, and that sort of inspired the webinar that we hosted. So I think maybe we can put a link to that video in case someone's curious, but I would love for you to talk a little bit about that. That was just, again, not my specific area, but I was so honored and thrilled. It was just an important piece of work. So
what was lovely is that it really actually links. It's a lovely segue, because part of the reason we met that day is because of the relationship that me and Suzy has built up. I was busy. I had so many things to do. And Suzy came to me and was like, she'd let me know that you were coming, but was like, oh, I've got a colleague Anne here. Do you want to come? I've got some biscuits, a bit of tea. Do you want to come? And I thought, I wasn't really going to have that much of a break, and I was going to eat at my desk. And I thought, no, let me go. And I'm so glad that I did, because the opportunity that grew from it. And I think that I was really open and honest about not being an expert for FGM as a midwife. And you and Suzy were like, okay, great. So you can give us a midwifery perspective in terms of being a clinical midwife and how that has an impact on you and the care that you provide when you come across a woman who's experienced FGM. But also you can then link us with the experts, which is what we did. Mm-hmm. Which was absolutely amazing. So we had Comfort Momo, who is a midwife who specialised in FGM since the very beginning of specialist FGM support and clinics in London. And she was absolutely brilliant. And we also had Shamsa Awilo, who is a FGM survivor, but also activist. And she shared as well about her experiences and what she also wants to see as a change in the UK. And so that was really powerful for the healthcare professionals and academics who were on the webinar, but also for the students. And also talking, and we had one of your colleagues as well, Anne, didn't we, who came on and talked about her experience as kind of a labour nurse. And we were able then to talk about some of the changes and differences between American healthcare and UK healthcare, and how it's viewed, and the interprofessional education side of it, and which professionals have which part. And it is different here, and it's often the midwife's responsibility to kind of ensure that all the information is shared appropriately to the people who need to know about it, so that we can safeguard that woman and that baby, but also to ensure that we are not discriminating against them, and that they are feeling cared for, and that they feel that they are getting a positive experience. So I really loved doing that, and I thought it was a really lovely opportunity for us to work together. And then we also went to a conference together. We went to the International Network for Health Workforce Education in Barcelona, which was lovely, a sunny work trip. And me and Suzy presented about MidMed, and you two presented as well. And so we also were able to take some students over there, and that's all down to Suzy and the great work that she does at SEAL at the university. She was able to provide us with the opportunity to go, but also with the opportunity for us to showcase what we do, because I don't think we're great at that. We do great things and we're not good at going, oh, by the way, we're doing this, and it's not just about patting ourselves on the back, it's about sharing good practice, because there were so many professionals that were from all parts of the world that were saying, oh my gosh, that's great. Oh, how did you do this? And this is an issue we have in our country. I had a healthcare professional from Singapore asking me questions. And so we forget the benefit of also sharing our kind of good practice and knowledge.
Yeah. And that was a great conference because it was smaller but it was very IPE specific. And so everybody that was there was really into it. So it was like perfect. You could not like meet a wrong person. Like if you were like everybody
pages of notes. Pages of notes and a lot of action points from that conference. It was wonderful.
And the sunshine didn't hurt.
It did not. Vitamin D for sure.
Yeah, exactly. Well, and that's coming. So we have talked, I guess, on the podcast, but then they've got one coming up in 2026 October. It'll be in Dublin. So I think we'll be sharing more about that later in another episode, but it'll be good. So if anybody comes, they can see us there, hopefully.
Yeah, hopefully.
Do you want to talk about what you're doing next? Or I guess you can kind of say where are you now, and then kind of what are next things for you? Because you've taken some time off.
Yeah. Just been chilling, had a baby. I'm actually currently still on maternity leave. So I had a baby in June, so she's 6 months old. It was my first baby, and so I'm adapting and adjusting to motherhood, but also having experienced the service that I used to provide and still provide was really strange. And in some ways, it was eye-opening that I could experience some of the challenges or see some of the challenges that I have been working to improve with my students, and with the work that I do with my colleagues, but also quite reassuring to see some of the positives and the brilliant care and the support that I knew existed, but it was nice to experience it from the other side as well. And I think I was mindful that in terms of just me on paper, I do fit that statistic of those women who are at higher risk of mortality or morbidity occurring because of simply my race. And so I was mindful of that, and I do think that sometimes does come into play. And I think that there was times, unfortunately, where I would argue that potentially unconscious bias occurred. The assumption where she's saying she's in pain and we will give her something for the pain. However, we're not convinced, and that's seen in the plan that we make. Does that make sense? So rather than we're not going to do anything because we can't do that anymore, that's not okay. We know that that's not acceptable. We won't necessarily act as swiftly as we could. We'll kind of just sit and wait. And it played considerable role into my birth experience, and actually all worked out in the end. I was really, really thankful that I was able to have my friend care for me in labour and deliver my baby, and that was brilliant. And it really helps as a midwife to have somebody who you completely trust, because it means it's a lot of control that you're letting go of. One, as any woman who's birthing and having a baby, but also as a midwife, because you know way too much. So it was really nice to be like, I completely, trust you. And if you say this is what needs to happen, then I know that you've considered everything and you're going to advocate for me. So yeah, that's what needs to happen, But, I did have some experiences. Antenatally, I had hyperemesis, which is severe nausea and sickness. I was still being sick physically from, up to 36 weeks pregnant. And yet, in terms of my primary care and my general practitioner, my GP, I had to push to get the medication that I wanted after trying a range of different antiemetics. I was told, no, the policy or the guideline is you can only get this medication for a few days. I was thinking, that's not the policy or the guideline. Well, you need to get your consultant to write a letter to confirm that you want this on your repeat prescription. And I thought, in that moment, I'm exhausted. I'm in the 3rd trimester. The risk that's associated with that medication, it's ondansetron. There's been some research about it having caused issues with the development of the cleft of the palate and lip, so it can lead to cleft lip and palate. However, some of that research has been refuted. But either way, in the 3rd trimester, it's irrelevant because it's already developed. So I didn't understand what the apprehension was. And sometimes what can happen is a woman's pregnant, and anybody who's not a specialist in maternity goes, oh, no, get a bit scared and worried because there's a baby involved. And I understand that. But if I was the average woman and didn't have an understanding of the process, of the policies and the access, I don't think I necessarily would have pushed as hard, and I would have been able to get my consultant to, write to the GP as I did and get it on my repeat prescription, and probably would have suffered for longer. And so that was quite frustrating. And I was actually doing pregnancy yoga at the time and hadn't told any of the other women that I was a midwife, because I thought I'm just going to be inundated with questions and queries and stuff when I'm trying to relax and, woosah and yoga. So on my last session, I told them, and I just said to them, this is something I've experienced, so I really want to tell you to advocate for yourself, or have someone there for you to advocate for you, because you are entitled to it. It's not about deserve necessarily, you are entitled to it. So even if it's phrased as if you are being difficult, or if they're making an exception for you, actually no, it's the basics, it's the standard. You are entitled to it, and I think that that's sometimes where we can go wrong in healthcare in general. I don't think it's just a maternity issue where, you feel as if you're wasting that person's time. There's different generations of older generations. It's this idea of you can only talk to the doctor about one thing. You can't mention anything else. There's only one thing. And I'm saying, well, why? If you mention something else and they say, you know what, we're going to need another appointment for that, fair enough, and book another appointment. But why not ask? Why not bring it up? And that's where then health issues go unresolved. They worsen because people are scared to actually bother someone whose role and job it is to care for them. And I think that that's sometimes quite dangerous.
I think that's true. And I think advocating for yourself, you are a midwife. You know what kind of medications you can and can't have. The average woman is not going to know that. No. They'll have no idea. And if anyone says something to scare them, they might not even understand the full developmental process to be like, no, well, you're bringing that up and the baby's well past that. So this is not an issue, right now. That might still ping. They'd be like, oh, well, what if then that, they're not going to understand what that means and at what point that would impact the baby, and that once it's completed then that cycle, then that's not an issue anymore.
Yeah, I think it's the power of language. So even you saying, well, the guideline says that I can only prescribe it for 4 days.
Oh, yeah.
That's it. You're then going to be, as the average woman, go, okay.
Yeah, I've had my 4 days, so
yeah,
I better not ask for any more.
Yeah. When actually, no, that's not the guideline. Yeah. That's based on what? Even if it was the guideline, based on what? That's not that. What the specialist is agreeing with. This is the plan put forward, and I think it's having the confidence to advocate. We talk about advocating a lot, but the confidence that requires, and I experienced that firsthand, where when I think there's a, I feel, but when I trained as a midwife, it was like quite routine for you to be like, okay, well, I'll challenge that as a midwife. You're with woman, that's your woman, that's the family that you're caring for. So if you don't agree with the plan, or you don't agree with the rationale for the plan, or if the woman wants to speak to a second professional, or if the woman wants to speak to the consultant, you give them a call. There's a lot more apprehension now and lack of confidence. And I think partly that's because it's lack of practice. So it's been a knock-on effect of women aren't asking anymore as much, because we have this, and I don't know if it's just in the UK, but this idea of we're bothering people, and we know how run ragged they are. We see it on the news. Midwives are, chronically understaffed. And you constantly see it, these lovely families saying, gosh, have you had a break? Oh, you've just been running ragged. And it's like, yes, it's busy, but you still are entitled to good care. So if you need something, you tell me you need something. So I think because women and families aren't asking, midwives are not having as much practice escalating, advocating in that way. And so they're more apprehensive when they're asked to do that, or when they're required to do that. Whereas that was just a kind of another skill, that I had, and that was nurtured regularly when I was kind of newly qualified.
But I love that you, I'm sorry, go ahead.
Go ahead. No.
Okay, well, I'm just going to say I love that you talk about it as a skill, that you talk about it as a skill that can be practiced. Because I'm kind of, again, a little bit different perspective, but with all the IPE that we do, using your voice to advocate for the patient, but in different ways. And sometimes that can just be being curious and asking a healthcare, another member of the team, I'm curious about this, or I'm wondering about what the patient said, for example, and just using that as an avenue to practice using your voice as you develop that skill. So I'm really glad that you pointed out that it is a skill and that we can get better at those things. And it's something that when I work on IPE, developing IPE, that I try to design that into the experience so that students can practice that. What were you going to say, Suzy?
I was just going to ask if I think some of that, if you feel like that stemmed again from COVID, because I remember during that time, it was very much like, do not go unless something was an emergency. I mean, I was pregnant during that time. It just still felt very like very limited, and it was like, you're not supposed to be bothering them, you're not supposed to, and then really since then, like, oh, they're overwhelmed, the health service is overwhelmed, and then since then it's been like, okay, but we're still overwhelmed, we've not recovered, we're not like even like caught up in all the waiting lists and things, and so you really shouldn't go. Don't go unless you absolutely need to. Don't go to the emergency room unless you absolutely need to. Leave, And it is almost like, if I think to ring the GP, I'm like, gosh, I'm really going to add to their workload today. Do I really need to ring them? And that's kind of, I think, it's different.
Yeah, I think I've never thought about it that way in terms of COVID, but I definitely think there's been an impact. There's an impact of, now compared to 20 years ago, our access to information, whether it's misinformation or accurate information, is increased so much. So therefore, women and families, which is sometimes positive, are aware of the difficulties and challenges that we're having in the service. But what can then happen is then they're scared to access the service in the way they're entitled to. So I think you're absolutely right. With COVID and everything else, everyone was like, okay, bare minimum in terms of where we go, what we do, and how we interact with others, even in terms of healthcare. And a big push from in the public health kind of viewpoint for maternity was still come in. If you have reduced fetal movements, if you have no fetal movements, you still need to come in, because women were scared to. Understandably, we've never, well, not in my lifetime, experienced a pandemic before. So you're worried, and you're seeing in all of these, again, lots of information about, you know, the people, the death toll and everything, all these different things going on. So I think there is that fear there. But I also think that, unfortunately, what often is highlighted in the news or sensationalized is the people or individuals who may be taking advantage of the services. So therefore you think, oh gosh, they must be absolutely swamped, because, you know, you've got those people who go into A&E when, you know, they've stubbed their toe or whatever, you know, and so, or you hear about the long lines outside of A&E, or you hear about the doctor strikes. And so we forget that as a patient, as an individual who's entitled to care, that we still have the right to have that high standard of care. And so that sometimes can be a barrier. And that also can be a barrier to those who are from ethnic minorities as well. And to Black women, we have to, you know, consider, and it's something that I talk about in one of our third year modules in the enhanced maternity care module, when we talk about inequality in maternity, and I talk about the historical aspect of during slavery in the UK and in America, Black women were experimented with to further obstetrics and midwifery with no anaesthetic. Black men were experimented on and given syphilis, them being unaware of that, just to see how it manifested. So there is a distrust among the Black community and healthcare professionals. There's a reason why there was a difference in terms of uptakes in vaccinations for COVID, in terms of, you know, COVID instances. We saw that in the US, we saw that here with Black people and with other ethnic minorities. And we see that in the global majority, we see that. And so we have to not ignore that. And that's something that I talk about the students with them. I say, you know, sometimes we have pushed to become so politically correct that we become fearful and defensive in our practice. And it is a real fine balance. We are not trying to discriminate or offend anybody. And I always say that sometimes the best thing to do is ask. What are your pronouns? What is your name? Use their name. And I always say this, you know, if you're in an emergency situation with students, you know, say to them, you're in an emergency situation, you don't know what their pronouns are, use their name. When had that been an issue? You know, I think we're thinking way too much about all of the nuances and the ins and outs of somebody's experience or what they identify as. And we forget that we've got something really quite simple that's individual to them that we could use. You know, and I think it goes back to sometimes those basics of, I would argue that any Black woman wants to be treated as a woman, as any other woman would be treated. So start there. And then consider all of the other aspects of the historical, you know, implications of the individual circumstances, of these unconscious bias, of this idea of Black women don't really experience, you know, pain as much as white women. They don't like to bother healthcare professionals, so they may not buzz. And when they buzz, they may be at a 10 on their pain score because they've waited until they absolutely cannot cope with that pain anymore. Whereas their white counterpart may have culturally been taught, call when you need help. So therefore may call when it's a 3. Now, this is obviously generalizing. There's different individuals who will be the opposite of that. But I think that that's what the point is of individualized care. And we sometimes lose that because we forget to look at the individual and consider all of the different aspects, and then think again back to that clinical picture, but what applies for them. And that's what I teach the students, you know, leave the unconscious bias at the door. And what I use as an example, because I think that race, gender, sexuality is always at the forefront. I use something completely different and it really turns it on its head. So I say to them, and I say to my first year students, I say, a woman, you get a call in the labour suite, you're a student midwife, and you get a call and say a woman's coming in and she's in the car, okay? And you see a white Range Rover 2025 pull up at the front of the hospital, because you're there with the wheelchair ready to take her down to labour ward with your practice supervisor, the midwife you're working with. And you see a woman step out of the car in a, you know, Ralph Lauren or Louis Vuitton dress and 6-inch heels, and her husband's getting out with custom Louis Vuitton suitcase. What are your thoughts? Be honest. Because we're human. So we're going to have some stereotypes, some bias. And often it's, she's too posh to push. She's going to want a cesarean. She's going to want an epidural. She's probably not in as advanced labour as she's saying. They've got all the money in the world. They probably want private. They probably don't value the NHS. And we talk about it. I was like, let's talk about it. You have to acknowledge it to be able to leave it at the door. And I said, that is exactly the same as in terms of any other protected characteristic. But we pretend it's not there, and that's when it can then creep up and affect the care that we provide, rather than acknowledging it and leaving it at the door. And so that's what I try to say to them, you know, as a way to kind of get them to break down some of those barriers.
I think what's interesting is the example that you just used, and then the previous examples, that's in both cases, the healthcare workers can assume that the patient is not going to trust them and that they don't have faith in the care that they're about to receive, and that you start getting defensive. You're like, I know what I'm doing. I'm here. How dare you question me? I know, I'm like, you're talking to me like I'm stupid, or like I don't know what I'm doing, but I'm a professional. And it like hits down, especially if you're feeling, for whatever other reason, slightly like, not very confident, and you're not then taking the patient seriously when they're expressing what they need to you, and you're dismissing them.
Absolutely.
And that,
go on.
I
was going to say, all you have to do is to add to that scenario, which I might do in the future, is have a doula come out the back seat. Oh gosh, then as a midwife, you go, got someone else who's going to try and get involved, and I think that also it applies to our colleagues, in terms of we then get defensive because we make assumptions of how they're going to feel or how they're going to be with us. And I think that we then can sometimes go with a bit of a chip on our shoulder. And what I also teach the students I give them an example, right? You're on shift and you're working with your practice supervisor, the midwife you're working with, and the senior midwife in charge of labour suite. Then you've only just, helped facilitate the birth of a baby for physiological birth. You haven't had a break yet and it's 1 o'clock, and then you're given another woman who's in active labour. Right, and they're like, oh, the first thing they say is, because the senior midwife's just not got a clue, she doesn't understand what's going on with it. And I say, all those feelings are valid. Now let's look at it this perspective from that senior midwife. She's got 3 midwives less than she needs to be able to provide the care. She has got 2 women in theatre. One of them is in poor condition. She's got a woman who's on the ward who's about to birth and really needs to come with a labour suite, but there's no rooms. She's got, and so I say it's about having empathy for each other. And when that comes in, what happens is in those situations and those hypotheticals is that senior midwife comes with a cup of tea for you and brings it into the room and says, I'm so sorry that you've had to have another labouring woman. I'll fill you in a little bit later on some of the challenges we've been having, things like that, and then facilitates a break for you. And also that practice supervisor says to the student, you go for a break, so that's the empathy that we need to kind of get back to. And some units are brilliant at and are still doing it now. And I think that when that's at odds, as well as your interaction with your woman and the family, and you assume that they don't trust you, then it all kind of falls apart.
Yeah, I mean, so much of it's around good communication, though, right? I mean, you have to communicate, yeah, and that's vulnerable. You're putting yourself in a vulnerable position sometimes, and that can be hard. You have to have a high level of compassion for others and for yourself to be able to be like, okay, like, it's okay to feel your feelings, but you can't act on them. like, it's holding that. But
Yeah, we've
gosh.
got to remember we're not working in isolation, but we're not going to be reminded of that sometimes when you're in a challenging situation, you're stressed, you're hungry, you're thirsty, unless someone says it to you. So when I used to coordinate the postnatal ward, I'd say to them, I'm sorry, I'm going to have to ask you to take another admission. I know that you've already got 5 women, but so-and-so's got 6. So-and-so's just had an admission for a post-cesarean section, so's doing hourly obs. Then I've just taken on these 2 patients from them so that they then have, so they understand the whole picture a bit more. And it's like, okay, I'm just, mucking in and getting part of it and helping out, rather than I'm in isolation and you're just giving me another person to care for when I've already got 5 women. And that's where sometimes that communication can kind of make or break a relationship and also the atmosphere on a shift.
Right. The trust, right? The trust on the team.
Yeah.
The trust that you're going to give me something because it's going to be best for the big picture, rather than not trusting you and assuming that, I'm just the next nurse you saw, so therefore, or midwife, so therefore I'm the one that gets the next, the delivery. So it's about trust on that team, I think, too. Closely tied to the communication piece, obviously.
Yeah, those are the best shifts I've ever had. Some of the best shifts I've had have been the busiest shifts in terms of the clinical picture and workload. Every bay is filled with women and babies. I've had some Christmases like that, but we've got a great team on. Everyone's communicating, everyone's looking in, everyone's helping each other, and the day has flown by. All of the women feel cared for, and we've had a great day. Rather than having a situation where you have one person refusing to take any admissions because they feel like they're being singled out, which then increases the workload to everybody else. Everyone else then thinks, well, I might as well work in isolation because then I don't have to help anybody else and I can get on with my work. Do you see what I mean? It then just has like a knock-on effect. So I think that sometimes that's lost. And I try to kind of get that back to the students about that respect, that empathy, that consideration of, yeah, sometimes we don't have the best leaders and the best managers, but often we do have people who are trying to be compassionate and thinking of the big picture.
So my next question for you is, so everything that you've been through, especially recently with your own birth experience, how has that impacted, or what are your thoughts now coming back? Because you're going to come back spring starting. What is that going to be? Are you bringing new things now or wanting to do different things with IPE or just your students? What are your thoughts?
I think, mid-med is our baby. So I'm looking forward to getting mid-med back and running. I think that communication needs to have a focus in a different way, and maybe as part of mid-med, to be clear, it wasn't all in clinical skills. Some of it was in classrooms with those healthcare professionals and was talking with students about different scenarios that we've posed for them that were concentrating more on social issues rather than specific kind of clinical emergencies. And I think that is something, and we also had a panel as well where students could then interact with those healthcare professionals and ask them questions. And I think that I'd love to get back to that. I think the advocate part and the empathy part, I want to kind of instill a bit more in my everyday teaching, but especially in mid-med. And also it has inspired me to remind the students that it's those little things that you remember. I remember the scrub nurse or the ODP, and I don't remember their role because they didn't tell me, but saying, have you got a camera that we can use? Have you got a phone to take pictures when the baby arrives? Things like that make all the difference, because those pictures are the ones that those are the memories. Oh, have you got any music you'd like? Those kind of things, those little things that's nothing to do with your clinical knowledge, nothing to do with your, seniority in that situation. It's just a bit of compassion and remembering that individual's a person and this is their life. And so, those things are really lovely. And also that camaraderie of staff and colleagues. You know, I had colleagues come down from the postnatal ward because they saw my name and was like, oh, you know, wanted to see me and the baby. Just lovely things like that. And I've been able to trust, you know, my colleague and being like, oh, right, okay, knowing my colleague, but also friend was going to look after me. And so, yeah, those things I would want to instill in my students and continue to instill in them.
I can't wait for you to come back.
Oh, it's gonna be great. I'm reminded as you talked about that, how in healthcare we just meet people that we don't know, that have no idea about our background, and we expect them to give us that trust in the initial moments of meeting them, and how much we ask of people. You know, we're prepared to go into their life and try to make a positive difference, but we really ask a huge, huge leap of faith from them every time, don't we? And I think it's easy for me to forget that sometimes. So that's a powerful reminder. Thank you for that.
Oh,
yeah. And I mean, in their most vulnerable moments. I mean,
exactly. I was just thinking about that, because
Yeah.
if you're walking down the street on your best day and someone says, can you trust me wholeheartedly? You'd think twice. Never mind when you're feeling unwell, about to have a baby, having some, you know, major life-changing experience, whatever that may be in healthcare. And then it's like, so I want you to trust me with your life. You know?
Yeah. And that's, I mean, you went in there, it was trust you with your life, your baby's life. And while we're at it, we're going to make sure that, you know, because this is like going to be an amazing moment for you in your life, we want to make sure that you've got photos and that you can, you know, and help you to like make this, it's not just about let's get the baby out, but like, you know, you've got, there's more to you because you're a person and a human. And it's like, this is also a huge moment in your life.
Yeah.
So
because you forget about the ins and outs when you actually experience it as a service user. You forget about the ins and outs of some of the clinical things, you know, maybe a little bit less for me because I know what they mean, but you concentrate on those moments that are, you know, immortalized by that picture, by that memory, by that song, you know. And I remember that my consultant had said to everyone, has everyone read her birth plan? And everyone's like, yeah. And you know what? It was almost like I was like, oh, okay. Because I knew that then people had heard me. I didn't need to stress. And so that was, I understood from the perspective of a healthcare professional, the power of us, you know, reading and acknowledging a birth plan, but I hadn't experienced it. And that relief that you feel. And also seeing it come to play where certain things happened that I had put in my birth plan of, if this happens, this is what I would like. And it was just going like clockwork, like that would already be the plan. And it may have been. But either way, I felt heard, I felt listened to, and I felt cared for.
Is that standard to in a birthing situation to announce? Basically, you're announcing it to the patient, right? But to say out loud, has everyone read the birth plan, and then get that confirmation back? Because I'm thinking if that's standard operating procedure, every patient should, I bet, would get some sort of comfort out of knowing, out of hearing that in that moment, like, okay, like you did, they've got the plan, they know what it is that I want for me and for my baby.
Yeah.
Is that standard?
No. Okay. No. But I do think that it depends on the situation. I think that I was in a situation where it's more likely, where I had a range of healthcare professionals present because they were doing the ward round. And so there was an acknowledgement of my birth plan then and there. But I think it was, again, I was advocated for by my consultant who knew what that meant to me because I'd already spoken to her about it previously when I was antenatal. So I think it helped someone bringing that up because I think they already had read the birth plan, but then voicing that and me hearing it meant so much to me. And I don't think we do that last step often because we don't think like we, you know, as midwives, we talk to them and talk about their birth plan. But once it becomes interprofessional, especially in an emergency situation, I think we need to sometimes acknowledge, or even at the very least, because I remind my students that there's only so much you can do. So you can say as a student midwife, I know that my supervisors let the consultant know and let the anaesthetist know about your birth plan. That's what you can do. You can't control what the anaesthetist does, or what they, you can say, I have let them know about the relevant parts for their professional, whatever, for the birth plan. And that's, again, that relief and that reassurance.
Yeah, because I definitely didn't get that for mine. But again, I think everyone is different. But that would have made me feel so much more maybe comfortable, I guess, like seen, I think, and that's kind of where.
Because you have to also remember that
it takes time to make
from
that
the
birth
healthcare, but from the healthcare professional's point of view, you're doing something you've always done. So not so much now, but anaesthetists always used to put, when you go to the theatre for a cesarean, whether it's elective or whether it's emergency, is they used to put all of the ECG kind of stickers, and they just put them where they'd normally put them, and forget that you may want skin to skin. And we'd have to consistently remind them that this lady would like skin to skin. So then they would kind of position them in a way that there was more space with your skin exposed where the baby could go on. And so those things have become more routine, but that's based on the midwife already having that conversation to know what the woman's wishes are prior to that moment, and then advocating for her in that moment to say, oh, sorry. And even if it's inconvenient because you happen to be distracted and you were, I don't know, handing over to the neonatal team, and you come back and the ECG stickers are already on, still saying, oh, sorry, can you move them around because actually she would like skin to skin. That's the advocate part that I think that healthcare professionals, not just midwives, are losing some confidence in, based on either not having to do it as often or not feeling as encouraged to do so.
Okay, yeah. Our first question. What is one thing about your own healthcare profession that you wish other people knew?
What's one thing? I suppose I would say that, like any job, there's good days and there's bad days. I think that part of, I didn't just say this in short, but part of the issue that we've had with the public perception of midwives, being somewhat negative at times in recent years, is because we put it up on a pedestal too high, and that we as a nation in the UK thought that it was all rainbows and unicorns, and that they just sat there and had a cup of tea and waltzed into a room and was like, baby. And so we're now like, excuse me, how is this happening? And it's like, yeah, because it's a job that can be really challenging, and that unfortunately, like in any healthcare profession, some people aren't well and some people don't survive, and that's not necessarily at the hands of anybody. And so therefore, I think that if people knew more about that, I think they'd have a bit more compassion.
Do you have a favorite medical word?
I think I quite like cephalic. So that means
Yeah, can you spell that for me first?
It's a weird word. It's spelled CEPHALIC, and it means the head presenting. So if you say that, it's a cephalic presentation when you do an abdominal palpation, that's cephalic. I like that, cephalic and palpation. I think they're quite nice words. They just kind of roll off the tongue. But I do feel that they're often, I think also why I like them is students often trip up over them, and we have a laugh and a joke because it's a whole new language that you learn when you become a medical professional, so you hear palpitation, or you hear cephalic, or all sorts of different variations of it. So yeah, that's what I'd say. And we actually do sometimes kind of like medical word tests and see if they can remember what they are, and acronyms and things like that.
What is a profession other than your own that you would like to attempt?
Stay home mom. I say that in jest because I think I love my job enough that I want to be able to do both. But I'd love to travel. I'd love to be able to, and I naturally, because I'm a midwife at heart, think, oh yeah, do maternity care in a different country. But in terms of another profession, I think that I'd love to work in hospitality, but not necessarily in kind of your day to day, in more of a kind of, best hotels in the world experience. Just having a slower pace in life, and making people feel good, with a massage and a pedicure in the Caribbean or something, something which is not life or death.
Yeah. So is there a profession that you have in mind that you would think, I would never, ever want to do that?
Yeah, there's a few, because I'm just very risk averse. So anything that's up high, anything that gets you particularly dirty, anything outside, because I like to be warm. So, anything that combines all of those things, like a window cleaner for tall buildings.
Not for you.
I'm out.
Okay.
So
I love that it's very specific. Like, no heights, I don't want to be outside, I want to get dirty. Love that. What is a sound or a noise that you love?
The sound of heartbeat, of a fetal heartbeat on a monitor or on a sonic aid. It's something that I used to find when I first started as a student. It used to really was anxiety provoking for me. And as I have progressed in my journey, and once I was qualified, it's so reassuring. It's so reassuring. It's something that you just hear, and whether it's regular, whether it's in normal range, and so I find it really, really reassuring. And I loved it when I could hear it for my own baby when, I was antenatal. So, yeah.
Yeah, lovely.
And then as a child, so you kind of touched on a little bit, but what's a career that you imagined doing when you were a child?
Yeah, I think pediatrician was one of them. But I also wanted to be a hairdresser for a while. I think,
Ooh.
having my Bratz dolls and doing all that stuff, I think I really enjoyed that. And the idea of being able to chat and gossip with my clients. So, yeah, that probably was something I was interested in.
We could do that in the Caribbean.
It's very true. And I'm still, why can't we can just add it to the list of different treatments that we provide?
Sure.
There you go.
I'd go.
Let's go.
Let me know when you set up. Yeah. Road trip. So Zakiya, that's the end of our questions. Thank you so much. It's been such a joy. I knew it would be so much fun to chat with you, and I'm glad you were able to join us today. Thank you.
Oh, thank you so much for having me. And it's been lovely. It's been really nice to have a conversation and talk about some of these really important topics as well.
Yeah, thank you. And thank you for giving us the time while you're still on maternity leave too. So
it's no problem.
Yeah.
No problem.
Very kind. So before we sign off, we want to remind you, whether you are a student, a practitioner, or educator, the work that you do is important and can be very stressful, but you are not alone. Please take care of yourself. Let's look out for each other, and we hope you can join us again soon.
Thanks for joining us on this journey to better interprofessional education and collaboration. If you found today's conversation valuable, please like, subscribe, and share the episode with colleagues. Together, we can shape better practice through connection and conversation.